today's webinar. All right, welcome again to today's webinar, everyone. Social justice and mental health advocacy. My name is Daniela Labate-Cavelli, and I'm from NIAPERS, and part of my role here is to coordinate our monthly webinars. So I'm really excited today to have Dr. Philip Murray with us from the UC Davis Health Center in Sacramento, California. So just a couple of really quick housekeeping items to get through today before I introduce Dr. Murray and he gets into his presentation. So if we could just go to the next slide, please. As you heard, today's webinar is being recorded, and you'll find the recording and the slides, as well as a resource list that Dr. Murray has put together for us, posted on our website at www.niapers.org within a few days. We're also offering one continuing education credit for LMSW, LCSWs, LMHCs, and CPRPs. So everyone who attends today's webinar will receive an email that will link to an evaluation, and you'll get that email within 24 hours. And we ask that you complete that evaluation and then return it back to us within 48 hours and indicate on that form which CE you're requesting. Now, you also need to be logged into the Zoom room for the entire duration of the webinar in order to qualify for that CE. Dr. Murray is also allowed time for questions at the end of today's presentation, so be sure to keep that chat box active and just type in your questions throughout the webinar. I'll be collecting them so that we can get to them at the end, and be sure to type in those questions to everyone so that the entire audience as well as our panelists can see them. So let's go to the next slide. Just a little bit about Dr. Murray. So he is originally from Decatur, Georgia, and he completed his undergraduate studies at Howard University in Washington, D.C. He received his medical degree from Medical College of Georgia and completed his adult psychiatry residency at Harvard Medical School, Cambridge Health Alliance in 2014. He completed a chief residency in child and adolescent psychiatry at the New York Presbyterian Hospital Child and Adolescent Program of Columbia and Cornell Universities here in New York City. And Dr. Murray also has a master's in public health with a focus on health management from the Harvard T.H. Chan School of Public Health through the Commonwealth Fund Mongan Fellowship in Minority Health Policy. That is a mouthful. And he's worked on multiple capacities, including emergency, inpatient, and ACT team psychiatry. Dr. Murray was most recently medical director for adult outpatient medical service at Atrium Health, and he's worked to establish outpatient clinical rotation there for third-year general psychiatry students. He is currently the medical director for psychiatric emergency services at UC Davis Health Center in Sacramento, California. He is most interested in the intersection of health equity and social justice, delivery systems, and vulnerable populations, and strongly believes that interventions need to begin with systems of care. And because of those beliefs and his commitment to working with people towards recovery, it is my pleasure to introduce to you Dr. Philip Murray. So I'm going to be quiet now and go off camera, and Dr. Murray, you take it away.
Thank you so much for the introduction. Good morning. Well, yes, it's still morning there. Good morning, everybody. Thanks for joining today. You could be spending your lunch hour or lunch adjacent hour, some anywhere. So I appreciate you stopping by. So we're going to get into the talk. So I don't have any disclosures, despite that lengthy introduction. Also, I'd like to say the views expressed in this talk are mine alone and not those of my employer, just in case something goes left and I would like to be invited back. So going through it, I mean, as far as today's talk, the learning objectives are going to be increasing knowledge of historical context for barriers within the current mental health system, introduce the concept of social determinants of health and connect it to current treatment, highlight racism as a core social determinant of health that's important for all involved, but in case you didn't know, it's Black History Month, so I figured it's very relevant for today's talk, and provide a framework for advocacy in the context of structural challenges for health equity. I mean, at least looking at you guys' organization and things like that, I understand that you're working within different aspects of the health system. And the big thing is for today's talk, what I want to do is just kind of anchor you, I know when you're on the front lines, you can lose sight of just kind of the larger goal, the system and things like that, and it can feel overwhelming. So I'm hoping that in today's talk, it helps to kind of recalibrate and provide a little bit more of a frame, just some encouragement for the day-to-day work that we're all doing to, serve those who need us most. And so with today's talk, we're going to go through just an overview of the mental health system, talk a little bit about cultural competence, a little bit about health disparities, social determinants of health, cover a little bit about the consumer movement, and potential solutions. So like I said, we're going to try and do an efficient overview, but as we go through the talk, Daniela will be monitoring the chat. So if anything's pressing, let me know. Feel free to stop me and we can do a deeper dive on any of these things. But the goal is to just kind of be helpful and encouraging. So going from there, so looking at a little bit of mental health history, I didn't go all the way back to the times of asylums, of Freud and all these other things, but looking more at kind of where the foundations for the current system in the US specifically started off. And so the big term that you hear is deinstitutionalization. It's a big word that basically talks about the slow movement from a lot of inpatient state facilities to the community. A lot of things kind of led to this. Some of this was the discovery and introduction of psychiatric medications, starting off with antipsychotics, mood stabilizers, and things like that. Some medications that we still use today. Then there were economic pressures, and also there was just a lot of publicity and information getting out that the way that state hospitals did things at that time didn't always lead to the best outcomes, didn't lead to the best opportunities for health, and didn't lead to the best opportunities for wellness. So this is something that started occurring within the US in the late 50s, early 60s, and a big piece of legislation was the Community Mental Health Centers Act of 1963, signed under John F. Kennedy's administration. And what this did was ultimately set the foundation for the community mental health centers that we have today. And the thought was that with this brand new technology of these medications, everything will be fine and people could just go back into the community and live a full and fruitful life. Well, I think as you all know, and as I know, there were some limits to this model, and it really didn't take into account a number of things that it takes to function effectively in the community. I think especially in our country as of right now, the lack of social safety net has really been pronounced when it comes to people who deal with psychiatric disabilities. And so there's a term that instead of deinstitutionalization, it's called transinstitutionalization. And that's basically people moved from state hospitals to different facilities. Now, because of years of advocacy, you can see a lot of this more in kind of nursing homes, disability based facilities. But then on the other side of it, because of the failures of the social safety net, you can also see this reflection in homelessness, in jails, and things like that. And so that's something to think about when it comes to just the systems of care that we have and a lot of the deficits that we have. And also with this kind of starting in the 1960s, it was while there was a rise as far as health insurance to cover services. And so within that, when you come up with a kind of financial and fee-for-service model, the business model, and unfortunately, is the less services you provide, the more profit you can make. And we've seen this in how mental health services are not reimbursed at the same rates as other medical services and conditions. And so there have been multiple attempts and legal interventions to have mental health parity. And that means basically that services are reimbursed at the same rate to ensure funds, because that is something that leads to consistent limitations. And within that, there have been limited opportunities for federal reform. So the Community Mental Health Centers Act of 1963 was huge, but it had its limitations, and opportunities to update that at the federal level were limited. I think the last kind of big push, you would say, was with the Carter administration in the late 70s. And so they made a lot of progress at that time, including peer representation in some of their commissions. But unfortunately, when we got to the 80s with the Reagan administration and others, especially in the era of fiscal responsibility and tightening, a lot of those reforms went away. And that was what started a lot of the commingling between the mental health movement and some of the disability rights movements that led to the way that things are reimbursed and funded these days. And within all of this, My psychiatry colleagues, other clinical colleagues, were guided by the DSM, which is now in its 5th iteration, most recently in 2013, and it's currently undergoing another update. And so, this is kind of the handbook, a Bible, if you will, that healthcare professionals in the US and much of the world use. It initially started as a way to just kind of classify things. Now it's become an industry standard. And within it, the information can determine coverage, what is reimbursed by insurance, and a lot of the, I guess you could say, kind of foundations for a lot of the evidence-based things that we look at. And so one thing that I want to highlight is that this document is not something that's perfect or exists in perpetuity, but it's being consistently updated. And so, from 1952 to now, a lot of things have changed. One of the most notable things that people talk about is homosexuality being changed from a mental disorder in the 1970s. And a lot of that occurred through advocacy. And I think that's going to be at the root and in the background of our talk today. So going with it, we have this system that kind of was rooted in the 60s. And so what is it really doing for us? And if we look, not just in the US, but across the world, we have not been knocking it out of the park. There's been an increase in suicide rates. That's 35% over the past couple of decades. Generally speaking, if you carry a mental health diagnosis, you have a risk of at least 2 times the risk of premature death as the general population. Through a lot of statistical models, it's estimated that there's 10 years of life lost if you carry a mental health diagnosis. It varies across different diagnoses, with the most pronounced years of life lost for psychotic and more severe mood disorders versus depression. And so from the onset, people would think like, oh, of course, mental health issues, a lot of the years of life lost would likely be to unnatural causes, whether it be suicide, accidental overdoses, or things like that. But actually, a lot of it is due to preventable conditions. Just because you have one diagnosis doesn't mean that you're insulated from a lot of the risks that other people have. So people with diagnoses are dying at higher rates of what we consider the preventable conditions. So this is going to be diabetes, this is going to be heart disease, this is going to be cancer and other things, and also twice as likely to die from COVID, to where, especially towards the beginning of the pandemic, people who carry mental health diagnoses were identified as high-risk populations who should be vaccinated. But within our systems, there are plenty of limitations that provide barriers to those. So, it puts those with diagnoses in a disparate position. And so, as I mentioned earlier, in the States, we had a model that was kind of built on this idea that medications can work, and not really looking at the totality of what it takes for wellness. But there is a model out there in a small city in Italy called Trieste. And so the model started in the 1970s. And so the model focuses on the person instead of symptoms. We'll talk about it more. The idea of personhood and mental health now is something that I would say relatively we take for granted. It took us a while to catch up, but they started this from the outset with system design. Treatment planning focuses on client goals. We'll get into how that kind of made it a little bit into our model, but they thought of this from the beginning. And a huge thing is social inclusion. And so it's not just something that looks at, kind of rating scales or things like that. It creates a more robust plan, so that way people can achieve goals. And you can see this in the budget priorities. As I talked about not too long ago, the funding is not secure for mental health in this country, but what they did in their model was put most of the funding towards social services. And this is included in supported employment and housing. And I think, for the work that you all do, you guys understand the significance of this. And 6% is for acute care. And so we're not saying that we're doing away with things completely, but kind of flipping the model to really serve those. And so this model has had a reduction in suicide and symptoms, to the point that the World Health Organization has been collaborating with the city over the years to try and roll this model out to others, so they can kind of replicate some of the success and take some of the things that are working and really customize it for the things that they're seeing. So, as we're looking at limitations and things that prevent us from implementing this model, one big thing is access to care. And so this map here, it has a lot of colorful graphics and things like that. And so this is about mental health care professional shortage areas. This is basically areas where you don't meet the needs of the population based on the number of mental health professionals there. And so if you look, as far as shortage areas, there are only a couple of areas that, kind of have less than a fifth to a third of mental health professional shortage areas. So there aren't too many places in the states that are actually knocking it out of the park. And I just wanted to highlight that this is a systemic issue that we're dealing with. And the pains that you're feeling in New York are being replicated in other places across the states. And so within this current fragmented system that we have, if we look at those who did not receive treatment, the last graphic and this graphic comes from the Kaiser Family Foundation. They're a great resource if you're looking for state-based just kind of demographics and facts about people who are being challenged by mental illnesses and resources and things like that. But at least in this country, a lot of the reforms and support is going to be towards those with the most severe mental illnesses. But even if you look, even those who have the most support, about a third of them don't receive treatment. I think that's something that is huge to think of, because as symptoms and things get milder and milder, you can get up to more than 2/3 of people don't receive treatment. So clearly there are some things that we're doing here that are just not working for what we're trying to get accomplished. And so, as I mentioned earlier, the idea that people with psychiatric diagnoses die earlier than others, that's something that we would call a disparity, meaning it's two different outcomes for groups based on different demographic factors and things like that. And so according to the CDC, health disparities are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. So I think all of us would agree that our colleagues, clients, all who carry a mental health diagnosis, because of just the social framework and things that we're existing in, are a socially disadvantaged population. And I think that's a lot of the work and advocacy that we're trying to do to kind of close that gap. On the left is just an image from Unequal Treatment. It's a landmark study from the Institute of Medicine that kind of looks at health disparities and errors within the healthcare system, and disparities in psychiatric care is a book that really helps to outline some of these things. And so when we look at disparities in care, race and ethnicity is a huge thing that, as of now in this country, continues to a lot of times correlate with social disadvantage. And so there's less treatment, there's poor engagement in care for those who are sexual minorities with different sexual orientations. There is increased mood disorders. Within these kind of different groups, there's a lower socioeconomic status, meaning that you have less resources. And a lot of this has now been distilled into concepts of social determinants of health, which we'll get to a little bit later. And so with this, a lot of things, as far as socially disadvantaged populations, can correlate with culture, race, and ethnicity. And so that's where we see other disparities, especially for those from those backgrounds. And so there's stigma associated with mental illness. That is an entire talk on its own of kind of how that comes on. Within those health profession shortage areas, even then, there's lack of providers from diverse backgrounds, so that can impact some of the therapeutic alliance and understanding some of the context. There's been history of discrimination with health insurance. Nationwide, not all states have expanded Medicaid, which usually helps those with more severe diagnoses, while New York is a state that has made that expansion. And also just distrust of the healthcare system, which also goes into that stigma piece with legacies of mistreatment still relevant. We'll talk about that a little bit later, but this can lead to less access, poorer quality, and just ongoing barriers that increase the overall burden of dealing with some of these conditions, especially when you don't have all of the social benefits at your disposal. And so within this, now a lot of this is going to be from the cultural formulation within the DSM, because over the years, my colleagues on the psychiatric side of things have tried to account for these things and basically get them right. And so cultural competence, the phrase has come from a number of places. This one's from the Joint Commission in 2010. So it says the ability of healthcare providers and healthcare organizations to understand and respond effectively to the cultural and language needs brought by the patient to the healthcare encounter. And so what I want to highlight is this isn't something that is specific to mental health. This is to all of healthcare. And I think, some of the challenges that we have on the mental health side of things are just a reflection of the challenges within the larger system. And so looking at it from a provider standpoint, there are many aspects of cultural competence, including kind of a self-assessment, taking some humility as well about the limits of that assessment, valuing diversity, ensuring safety around power dynamics that can result from cultural differences, and responsiveness within adapting and kind of tailoring some of our treatment plans. And so when it comes to speaking with people in cultural identities, the big thing is inquire, don't assume. For us on the mental health side of things, this is what we would consider more of a formulation. Where you can describe the individual's racial, ethnic, or cultural reference groups. For immigrants or racial ethnic minorities, also understanding some of the backgrounds or challenges can be very helpful in how you formulate things and how you interact with people. And so all of these things, the social identities, the ethnic identities, all of these things, the family identities can factor into how this person, deals with illness, presents with illness, and also navigates it, whether it's individually or through the support of the existing community. And a lot of this has to be factored in between the individual and the clinician. So for those of you out there who provide direct services, obviously, this is something that you would consider. For those who are providing support services, I think this is something that you can bring up with and talk with your clients about, so that way, these factors can hopefully be addressed to maximize the possibility that a lot of these things will go well, and maximize the possibility to get to wellness in the context of what can be a very difficult and challenging treatment paradigm. And so from there, there's assessing different features of the relationship. And I think a lot of times the way that it can go when it comes to socially disadvantaged people that we can work with, systems can put the burden on socially disadvantaged people to make all of the change and have all of the power and responsibility. But I think for all of us, no matter where we occupy on the totem pole or things like that, it is up to us to kind of advocate for these things, because I think a lot of times we can have access to rooms or conversations that our clients can't. And I think that's going to be a part of the advocacy that we're talking about, just kind of doing it at every possible level that comes up. But it's been interesting because cultural competence, a lot of this has been addressed through implicit bias training and things like that. There's this fantasy that a provider can kind of get it right when it comes to each person from a diverse background. And so there's been a different kind of thought about it, where it changes from cultural competence, where if somebody sits through a couple of lectures and all of a sudden they're an expert on what's happening with a certain group from a certain background, it can lead to them kind of closing themselves off to incorporating new knowledge, as this example here provides from a paper from Turvalon back in 1998, where we can take this new knowledge and just kind of also use it to the point that we exclude the person from participating in their own care. And so the other frame, also from Turvalon and Yeager in 2013, that we can kind of go with is this concept of cultural humility, where you take some of this information, but it's a lifelong process. It's something that also involves the self-reflection and self-critique, but more so checks the power imbalances. And it kind of forces you to check different assumptions, minimize stereotyping. And the big piece is that the institution within which this is happening, it has to be consistent there. So I think this is just further demonstrating that as a provider, as an employee, as somebody who works either within or with the system, a lot of this has to be replicated at higher levels. So that way it's reinforced, because one individual usually can't surmount all of the challenges that somebody is kind of facing that can come up. And so this has been distilled even further. So I graduated medical school in 2010, came to psychiatry as a form of social justice. And so back then, the kind of cutting edge terms would be more the health disparities framework. And so I think now this has started to evolve to where we're understanding more the ways that so many things that happen outside of the treatment context or the treatment room or outside of the hospital or the treatment facility really do have large impacts on the health outcomes and overall lives that people can live. And so even though this is now more being just taught in traditional ways and that we're having more access to it in these conversations, this isn't something that's brand new, but we're still starting to understand it. And so the social determinants of health as defined by the CDC is conditions in the places where people live, learn, work, and play that affect a wide range of health risk and outcomes. These conditions are known as social determinants of health. And so even though we've started to talk about it more in the past few years, this is actually something from decades ago. The gentleman credited with it is Dr. Thomas McKeown. He's a physician from the UK who was looking at kind of the rise of populations and lifespans and kind of looking at how a lot of the things that allowed us to achieve that weren't necessarily medical breakthroughs. It was the improvement in life overall. And so a lot of this we can see in things like education, unemployment, in different situations as far as housing discrimination and mass incarceration. And so, as I mentioned earlier, that term trans institutionalization, if we look at mental illness in correctional settings, compared to the general population versus local jails, state prisons, or federal prisons, it is wildly overrepresented in correctional settings. And so this says one of two things. Either this is saying that people with psychiatric diagnoses are doing more criminalized activity, which we all know is not the case. Whether it's violence, whether it's perpetrating large crimes, the evidence shows us that those who carry diagnoses are more likely to be victimized instead of the ones perpetrating these crimes. The same thing with housing discrimination, the same thing with homelessness. Again, all of these are areas where those with psychiatric diagnoses are overrepresented. And so that reinforces that at the systemic level, we are not doing our best or appropriate things to kind of serve people so that way they are not in these difficult situations. Now, one area that we do understand, or at least have factored in some of the social determinants, are adverse childhood experiences. I'm certain some of you guys have heard of them, but just want to go a little bit. And so these are potentially traumatic events that occur in childhood from 0 to 17 years. And so the original study was conducted at Kaiser Permanente, a obviously very large player in the health services side of things. And so went from 1995 to 1997 with 2 ways of data collection. And so this was surveyed with over 17,000 members, just kind of looking at their childhood experiences and current health status and behaviors. And so the unfortunate thing is these are common. Keep in mind, I'm not speaking about these being common just among people with psychiatric diagnoses. I'm talking about in general across the population. Something in the system is not quite working. And so about 61% of adults surveyed across 25 states reported they had experienced at least one type of ACE. Nearly 1 in 6 reported they had experienced 4 or more types of ACEs. And so from there, this particular area, ACEs can have long-lasting effects on general health conditions. So as we spoke earlier about some of those preventable things that can impact years of life lived, behaviors, a lot of things with coping and substance use, and life potential. So if we look at this and compare it to our last slide as far as social determinants of health, from the beginning, people can be put on these paths where it can be very hard to kind of course correct and get back to that. And so this particular slide, also taken from the CDC, helps us to see how these things occur. I think previously, when I say previously, I mean 10, 15 years ago, one could make the argument that, well, one could inappropriately make the argument that, it's all about personal responsibility and people not doing the right things. But we're starting to really understand and be able to document how these things can lead to some of the negative outcomes. And it can really highlight, just the impetus on kind of social systems and things like that to help pick up some of the slack. And so this is from a Surgeon General's report. And so it's looking at some of the strategies and approaches to dealing with the consequences of adverse childhood experiences and also trying to prevent them altogether. And so if we look here, we're not seeing things highlighted like, medications, hospitals, or things like that. These are interventions that are geared towards the things that people are experiencing that directly lead to some of these deficits. And I want to highlight that historically, because of how the reimbursements go and things like that, medical facilities, medical entities could more easily in the past kind of punt on these things and say, it's not the jurisdiction of the hospital. It's not our place to deal with these things. But I think now, as a couple of things are happening, is our ideas of health and wellness are expanding. And as there are some more financial kind of consequences with this, health care organizations are more incentivized to address these things. And so it'll take a while. It takes a multi-pronged approach, but it's something that we need to continue to go to advocate for. And so within social determinants of health, racism is a huge one. And it also kind of permeates every aspect of society, illness, and everything else. So while there are healthcare disparities, they are worse when you bring in racism as a factor, when there are mental health care disparities. Again, worse when you bring in racism as a factor. And so as we're trying to adjust this, the same way you've had to evolve our knowledge and thoughts towards health disparities and social determinants, I think also the way that we approach, log and catalog racism has to change, and so a lot of times, and so this paper is from Dr. Rhea Boyd and some of her colleagues. When it comes to a lot of the limitations or things like that, there will be kind of euphemisms or words to soften it without naming racism as a factor. And so to kind of go with it, the solution to racial health inequities, as it says here, is to address racism and its attendant harms and erect a new healthcare infrastructure that no longer profits from the persistence of inequitable disease. Again, that's kind of addressing some of the more nuanced things that can kind of come up that that can show why these things are perpetuated. Even though we have evidence, even though clinical trials have shown the benefits, there are clearly incentives that we have to keep some of these systems going. And so defining racism a little bit more, not to be confused with race in other terms. So race itself is a social construct, no biological basis, based on skin color. Bias is a preference, which may be favorable or unfavorable. A lot of times we hear bias and we attach our own values to it, but the term by itself is neutral. Prejudice is a belief that is often rooted in unfair assumptions, and discrimination is an action that is motivated by prejudice. And so while a lot of these terms are related, the way that they lead to some of the harm and bad outcomes is when all of these things kind of work together in the wrong direction. And so if you focus on race, that's one demographic that's not even rooted in biology, but you have to look at racism, which is the system of how all of these things can work together. But a lot of it is rooted in the values based on the social interpretation of how kind of people look. And so right now, at least, I'm not speaking about one particular race. I'm saying there are core similarities across different races and ethnicities as far as how people can be treated and discriminated against. And this is reflected in laws and policies. So these are decisions that we as a society make. And so a lot of this is core to a lot of the health disparities that can come up. And so there are three levels. There's institutionalized, there's personally mediated, and then there's internalized. This is more kind of explored in the paper by Jones, just kind of looking at some of the levels of racism, but there are mechanisms, that this can occur. So on the individual level, there can be stressors, there can be institutional discrimination, there can be separation, there can be reduced access to resources. And while a lot of this was more overt, kind of in previous years, it has become more subverted in, kind of industry standards and things like that, that can lead to, kind of policing practices, housing discrimination, job discrimination, and things like that, that can be difficult. And this can also come into different disparities within healthcare. So a lot of the differences in maternal morbidity and mortality, bias in pain assessment and how pain is treated, a lot of these thoughts can kind of negatively impact things. And so a lot of these race-based thoughts can also have come into research. A big notorious one is the Tuskegee study of untreated syphilis in the Negro male. And I think the thing that people don't really understand about this is that this was done by the Public Health Service. It wasn't done by some, shady kind of crackpot, kind of organization. This was literally done by the US government. And so it was initiated under the guise of treatment. It was supposed to go on for 6 months and lasted for 40 years. People knew about this, but it was so systemized, people didn't think to disrupt it. And another area that kind of the exploitation can occur is, if you all don't know about Henrietta Lack, she died from cervical cancer in Baltimore in 1951. A tissue sample of some of her cancer cells that were rapidly reproducing was taken without her consent. And this has been integral to research. Careers have been built on this, but there has been no benefits kind of transmitted to her family, or even the credit wasn't discovered until decades later. So you can just imagine some of the other things that kind of went on. And so the same way this occurred in the larger health system, mental health system is not exempt. And so if we look at, and so this is from a book called Protest Psychosis. And so this kind of looks at how some of the societal views of schizophrenia have changed over the years. And so this just shows how the mental health system, through some obviously outdated things, can lead to further harm. So condition leading to slaves running away, to one which was a disrespect for master's property that could be cured by extensive whipping. And then a protest psychosis, saying that the Black Power movement drove Negro men insane. And so this here is a ad for a very classic antipsychotic Haldol. And so I think you can see from this image a lot of the bias and a lot of the kind of unconscious assumptions that you can get about the people that need Haldol, about what the medication is for and kind of how to use it. But to control aggressive, assaultive behavior, that doesn't necessarily correlate with a diagnosis, with anything else, but it still kind of shows us how we can think about some of these different things. And so this can kind of come up in mental health treatment as well, as far as how race can be a factor in some physical restraints, or in psychotic disorder diagnoses as well. And so the same way there have been frameworks to deal with ACEs, there are frameworks to deal with racism. This is from an image of a paper by Dr. Darrell Gray and some of his colleagues in Ohio. But the interpersonal would be the implicit bias in education, some of the cultural competency things. And so that happens at the treatment encounter. Institutional is just going to be larger policies that ultimately dictate kind of how we carry out a lot of these things for the people that we serve. And the internal part is usually something that we can help to undo or examine as we have more close and intimate relationships with the clients that we serve. And a lot of this can be towards transitioning to anti-racism. So, all right, I want to make sure I get through a few things. So within our system, which clearly has not been working to the best of its ability, and a lot of kind of deficits outside of the traditional system, started the consumer movement that now informs a lot of what we do. And so this kind of started in the 70s as well. And so this mirrored other historic movements. And by that, I mean rights for a lot of socially disadvantaged groups, including women's rights, gay rights, and the civil rights struggle for African Americans back in the 60s. And so this rubbed off on those who had basically not been done well by the mental health system. So this came from treatment and policy failures. So initially, this was primarily with consumers and survivors. And so the coalition broadened over the years. That's when you have families coming into play with NAMI. And there's been, I guess you could say, some changes in orientation and views. So when the movement first started, it was something that was trying to come up with an alternative to mental health. Now, depending on where your beliefs lie and things like that, a lot of it is more about improving the system overall, as far as different ways to humanize those who go through the system, different ways to empower those who go through the system, and to provide a voice and give that input. And as organizations have widened over the years and have kind of gained a bit more political power. There have been policy victories to help inform things. There has been more space made for consumers, for family members, for those with lived experience to inform a lot of the decisions that we're making, because clearly, as we've seen from the earlier information, if you're doing it with just providers and those on the treatment side of things, we do not always get it right. And so I think this is really encouraged those who are in rehabilitation, in recovery, everybody kind of being empowered more as stakeholders and kind of looking at how that can impact some of the way that things go. And so within this tradition, this is where you guys come in, founded in 1981, right at the beginning of it, reaching over 20,000 people, promoting recovery, rehabilitation, and rights. And it's so interesting that this is something that we, when I say we, I mean psychiatrists and a lot of mental health professionals like myself, have had to be reminded of. It wasn't something where there was initial space for this because the system in and of itself could be so paternalistic. Now with the work that you guys have done and across the consumer movement, things, like patient rights, the patient bill of rights that has gone out, and a lot of just kind of different landmark court cases and things like that are slowly but surely making sure that there are more rights and things allowed within the treatment context so we can ultimately get things done. And this has required a multifaceted approach, and you guys are taking that, whether it's informing direct services, addressing social conditions, or providing information and frameworks for policies. And I can't underscore the importance of kind of coalitions and collaborations enough, because that's how we ultimately get things done. When you look at the current entrenched interest in the treatment system, whether it's looking at pharmaceuticals, insurances, looking at hospital systems, things like that, these are very large, powerful people. Well, not people, large and powerful entities. And so it's not something that can be faced without appropriate organization at different levels. And so we've found that rehabilitation focused treatment is something that can be helpful. So these are two studies that were focused on treatment groups within the Netherlands, but it used a lot of the principles that were developed in the US, particularly in Boston and New York, about what rehabilitation can look like in treatment. And so a lot of that has to do with reaching goals as a part of managing a treatment plan. So this is more than just symptom control, but this is the provider and the consumer working together to figure out, what do we want life to look like? What would define success? Because if you're only looking at symptoms and medications, that really takes away a lot of the opportunities to bring in other victories and kind of put together this life. And so the psychiatric rehabilitation model was a methodology to help identify and pursue goals in multiple areas. This improved social participation, again, as we're trying to do more social inclusion. And in a later study, attaining personal goals impacted the quality of life. And so within this, they used a number of scales. And so within the scales, there were subscales. And so working alliance, meaning the ability of the client and the provider to work together, was more important than just bond or task. And so the thought was previously that if there was a therapeutic relationship, then all these things would fix themselves, but that's not the case. And so I think a big part is the role of research. So when you're dealing with a lot of these larger entities or things like that, it is clear that the moral imperative or what is just or appropriate is not enough to make, to bring people to the table to talk about and agree on these things. And so research is a huge part of it. And so historically, there has been exploitation in research. We talked about some of the studies that occurred previously, but a lot of this can be reflected in the conflicting priorities between institutions and community. When it's driven by institutions, a lot of that can be reinforced by funding streams for certain types of discoveries, for answering certain types of questions, as opposed to going to the community and saying, hey, what can we help you with? And what are the best ways that we can serve you? And so a lot of this is being challenged under the framework of something called community partnered participatory research. And so ultimately what this is doing is kind of changing some of the dynamics. It is saying, hey, let's talk to the community at the beginning of kind of making these studies instead of just coming with something and dumping it in people's laps and saying, hey, can you help us with this? And so this incorporates community preferences, and it requires a longer term relationship. It requires coalition building, but ultimately it leads to better and more sustainable outcomes within the community. So when it comes to seeking social justice in mental health and really healthcare at large, it's a multi-level approach. There are things that organizations like you all's, like Appers is doing at the individual level, making sure that people have appropriate services, whether it's access to services, whether it's informing those services or how they navigate those services. All of that is just as important as the larger work that you may not be as connected to on the front line. And this is impacting policy, whether it's advocacy, whether it's directly lobbying, whether it's serving on boards where, within hospitals or systems, decisions are made. All of this continues to factor in, and all these things work together. And so there are policies that are done by organizations, but when I say systems, I mean literal overall systems, whether it's looking at economics, whether it's looking at housing, whether it's looking at policing. We have to be able to inform all these things and kind of take this multi-pronged approach. And since nobody has a monopoly on it, I, as a psychiatrist, don't have a monopoly on it. When it comes to families, communities, schools, peers, everybody really has to work together to kind of impact change at their individual levels. And so really wanting to say that even though, a lot of us are not at the top of the food chain, totem pole, whatever you want to say, there are certain privileges and access that we have. And I think maximizing that at every level is the way to do it. And I think providing that education, also just sometimes just being able to name things that are wrong. There's huge power in doing that, because I think a lot of times people can assume that the default is correct, and that's not always the case. And so within that, there are going to be a lot of incremental victories. And so you really have to dwell on those and be able to take those for what they're worth and take that as encouragement. But also self-care is a huge, huge piece. When we have kind of chosen this field where we're solving some version of the world's ills, it can be burdensome. There can be aspects of burnout. And so within that, the same way that we want to inform systems and clients, I think we need to do that and create that space for ourselves when we do that. And I think that's something that we need to be aware of, and making sure that we're taking care of ourselves the same ways that we are advocating for our clients to do that. And so I'm not sure if you all have seen this graphic before. I've seen it in a number of situations and in a number of ways, but I've usually seen it in the first two, where there's equality, which is giving everyone the same resource, but you can see that doesn't necessarily address the need. And then there's equity, which is giving people kind of what they need, so that way they're on even playing fields. And it wasn't until probably within the past couple of years, like I said, I've seen this graphic for over a decade at this point, that the idea of why is there offense at all, I think that is more the justice piece. And I think that's something that we're all working towards. And when you're the little guy on the box behind the fence on the equality side, and that's all you can be very satisfied with the box. But I think the more we can kind of take these perspectives and things like that, we can work towards hopefully something where the system at its default can work well for everyone. So to summarize and make sure we have a few minutes to talk at least, there are plenty of barriers within the current system, whether it's access to care, whether it's manifested as health disparities, social determinants of health. But as we've talked, a lot of this comes from a historical thing. This didn't just come up overnight. It's not something that was arbitrary. It is, unfortunately, for better or for worse, the result of decisions that have been made over the years. And so that's why progress has been so slow. Thankfully, through innovation and resilience, we've been able to kind of find our way around it, but we will continue to kind of have to work. And so a lot of this, as I mentioned before, there's evidence, there are use cases for a lot of things we want to prove, but this is something that we're going to have to continue to introduce in different spaces. And this is where I cannot underscore the importance of the work that you all do to continue to inform things and continue to bring that just viewpoint into different levels of the system. And a lot of it is going to continue to be done through strategic partnerships. So in conclusion, it is our responsibility to be mindful of social determinants of health and potential impacts, whether that's at the individual level with personal bias. Each case, kind of each person that we serve, each interaction is unique. And so, balancing these concepts of cultural competence versus humility will help to continue to inform and give us the flexibility to try and make treatment environments inclusive for just people from different backgrounds who are dealing with different things. But a lot of these things are tied to laws and policies, and that's where we really need to be aware of the historical factors. And I think a big thing is, especially in a country such as this that can focus a lot on individual responsibility and individual agency, it is impossible to overcome these challenges through individual effort alone. And so I want to help to provide that perspective of when we're on the front lines, working with people on a one-on-one basis. It is not our responsibility to change the entire system overnight, but it is our responsibility to do our best to work on things in a sustainable way. So that way, ultimately, our small incremental efforts can lead to bigger efforts. And I can't underscore this enough. These interventions can require a multifaceted approach on multiple levels and just collaborations across disciplines. So we have a few minutes left. I know I've covered a lot. So I'm going to open us up for questions at this point. That's my email for any follow-up information. And so Daniela, I will check in with you about about the chat box and getting that information as well.
Excellent. Thank you so much, Dr. Murray. There's been a bunch going on in the chat box while you were speaking. A lot of folks are asking if there's a bibliography and if the presentation will be posted anywhere. The answer to that is yes. Dr. Murray has put together quite a resource list for us. So we thought we would post that separately instead of putting it onto the PowerPoint. So you'll have the PowerPoint, you'll have the recording, and you'll have the resource list posted on the NIAPRS website within a few days. So be on the lookout for that.
And I realized on the resources, I included all of the papers. Daniela, I'll send you an update to include some of the books as well.
Okay.
Just so that way people can kind of have a more robust thing. And within the talk, you guys can't see it because it was in the comment section, but at least for most of the graphics, whether I got them from websites or other places, I included those links. So not all of those are necessarily from the papers, but the content and things like that, it should all be within there. Excellent.
Thank you. All right. So lots of comments and questions. I guess let's just dive in the time that we have left. There's a comment around creating service directives and setting priorities within frameworks and models that can be used as blueprints and social determinants of health sort of speak to a model that's needed. And the question is, does HRSA or the CDC or any other government or health organizations have a model for closing the gap for determinants of health and ending race and health disparities? So a huge question.
So I will answer the question from the best way I can, from the best way I understand it. So I will say on the face of it, I'm not 100% sure. And the reason why I'm going to say that is because a lot of whether it's SAMHSA, whether it's HRSA, whether it's the CDC or things like that, a lot of what they do is kind of provide the information and allow health systems, things like that, to kind of come with toolkits and kind of take it away. So that way they can make a more, I guess you could say, localized and tailored approach. Now, there are things like social determinants of health questionnaires. And like I said, there have been even pushes like the American Hospital Association has their 1, 2, 3 for Health Equity program, but I can't say that there's a one size fits all type of approach. I think if you were to check any of those organizations and just put in social determinants of health, they'll have a lot of resources on what people do. But I think the real kind of change and things that can come, because like I said, it's at multiple levels, would be, I think, just locally, just asking the question, even if it's at the treatment encounter or whatever else, it's kind of like, hey, are we thinking about this? Or rather, how are we thinking about this? I think, for example, within a psychiatric diagnostic interview or things like that, there's room for, a social history. But I don't think we ask specifically about the challenges that people that people encounter, but within kind of new electronic medical records, within especially pediatric offices and things like that, there are more questionnaires that are going out. And I think as we're gathering this information, I think we're slowly figuring out how to operationalize it. So the short answer, the way to kind of summarize that is, yes, there are ways for people to do it, but it hadn't gotten to the point that there's one way or something that's been rolled out across large numbers of systems. So it might take a little bit more research, and I will do my best to update myself, but that's kind of it as I kind of conceptualize and understand it now.
Great, thank you. Lots of comments around the role of peers and people with lived experience being an essential part of this work. So I just want to say that out loud and echo that, that the role of peers is sort of critical in mental health advocacy and social justice. I'm sure you can agree with that.
Yeah, so I mean, the thing, so I didn't go into the peer movement specifically. I tried to do consumer movement to kind of just highlight more the advocacy piece, but the peer movement obviously is huge. I think there's a lot of representation that is being increased and spaces being made for that within organizations. A big thing is within the ACT team model, assertive community treatment, peers are a part of the evidence base. I think a lot of this can also be seen through from the consumer side, kind of how NAMI has the kind of peer-to-peer relationships, especially with families and things like that. And I know that even at some state levels, like I know with Colorado, they're doing a lot of behavioral health reform. And even then peers are also being included. So I think, you know, this is starting to permeate as the value continues to be demonstrated, but you know, you can only kind of think about things as far as you can think about them. And while for me, you know, I consider myself a community psychiatrist, I'm always aware of kind of the roles that peers have played. I've worked in that model, but there, you know, a significant amount of people who are kind of private and kind of work and see people individually. And so they're not going to be thinking about it as much from a systems level. But yes, it is definitely essential to, you know, kind of the system because it's not a one size fits all type of approach.
Okay, great. So I have a couple more questions coming in. It seems that much racism, discrimination, and bias stems directly from the underlying assumptions about a disease model of mental illness. In what ways do you, as a psychiatrist, community advocate, and public health expert, feel a disease model of mental illness is useful versus destructive, and where should we dismantle the disease model assumptions about mental illness?
And so here's the thing with mental illness versus other medical illnesses or things like that is our definition of it is constantly changing based on society's understanding. You know, when it comes to, let's say something like diabetes or something like that, you know, you can pretty well document like, okay, you know, the body is not producing this one chemical, which leads to all these different outcomes. And so if we supplement this one chemical, this is kind of how we get it. So you have lab studies and everything else. And so a lot of the information that we have is going to be way more objective than things that, while there is the evidence base for it, the way it is applied can depend on each kind of individual practitioner or things like that. And so a lot of this can be seen in the evidence of, you know, two people can present with the exact same symptomatology and leave with two different diagnoses, depending on, you know, factors like race, among other things. And so all of those can kind of have their own treatment. All those can have their own treatment kind of correlations later on down the line. And so I think the issue is because so much of that is subjective, and so much of that can be colored or informed by society's understandings of what's acceptable at the time. I think sometimes it's helpful to go beyond just diagnosis and kind of look at everything that's going on to come up with a more robust formulation. Because to say that somebody has schizophrenia, you know, it says like, okay, these are the constellation of symptoms and this is what it means. But also people can present in different ways in different circumstances. And so, you know, whether it's informing diagnoses with trauma, whether it's looking at the practitioners' kind of views on bias and things like that. I guess the thing is, I personally don't have any issues with the current model on its own. It's more how the model has been applied and informed that has led us to this trouble. The same way that homosexuality was thought to be a mental illness back until you had a bunch of advocacy and stuff like that. So I think it's more about questioning assumptions as we use the model and bringing that into treatment. And as I've been training kind of residents, med students, and things like that, I kind of go through like, okay, here's what the diagnosis says, or here's what the past medical history says, but what are other factors that are kind of contributing to what's going on, and how does that change the way we see things? So it's the bad part about it is that when we're doing the right thing, it always takes just more effort, time, and everything to do versus kind of the status quo. It can take a lot of resources, it can take a lot of time, but it is absolutely worth it.
All right. Well, thank you so much, Dr. Murray. There are a lot more questions and comments in the chat box, but unfortunately we're a little over time already. So I want to be respectful of your time and everyone else's. Thank you so much for everyone for attending today. Thank you so much, Dr. Murray, for coming on and joining us today and presenting on this important topic. And we hope that we'll see you all in future webinars. Take care and have a great week, everyone.
Thanks so much for having me.
All right. Take care.